Yes, you know, but no.
Anjali, video is not running.
Good evening, all. It gives me a great pleasure while I extend a warm welcome on behalf of Maharashtra College of Radiology in this webinar series. Today, we are very lucky, privileged to have with us one more guru, that is Dr. Bimal Sahani with us. Welcome, hearty welcome, sir. All of us are doing obstetric USG and we do encounter anomalies once in a while. But fetal growth related problems, everybody of us, we do come and encounter these problems in day-to-day life. May it be a radiologist, gynecologist, obstetrician, or fetal medicine specialist. And that is the reason we should be very well versed with fetal growth related problems and Doppler. And who better than Dr. Bimal Sahani to enlighten us about this fetal growth? Today, sir is going to cover this topic in a very different way. He is going to give a lecture and later on he is going to discuss various case scenarios because all of us have requested him to do that way. Friends, technology is so smart, isn't it? When I type on my mobile screen, fetal growth restriction, immediately there is an auto type which comes Dr. Bimal Sahani. Because these two words are so synonymous and they are so closely related with each other. So, warm welcome to you, sir. Before we start with sir's lecture, I would request everybody to register for our Festival of Ultrasound, that is UltraFest conference. As usual, it is in the month of April, but the venue is a bit different. This year, the conference will be hosted at Pune in a very nice way. And we are going to have a galaxy of faculties who will be guiding us. And till this 31st of December, we are going to have a special discount offer, that is a Christmas discount offer. So I request everybody to register for this conference. And without spending much of time, I request sir to come on the dais and start his lecture. Thank you, sir.
Can you see my my screen?
Yes, sir.
Okay. Good evening, everyone. At the onset, Maharashtra College of Radiology and my friend Sanjay Desle and Manjusha, thank you very much for having me here. And in fact, it gives me great pleasure when I was very happy when you asked me that, sir, will you take something on FGR for this program, and I was really delighted to be a part of this. And as Manjusha has rightly pointed out that fetal growth restriction is something that we encounter on a day-to-day basis. Very honestly speaking, if there is one thing which is an endemic in pregnancy in India, it is fetal growth restriction. We have nearly 26 to 30% of Indian fetuses are small. And then the unfortunate part is that we don't have our own guidelines. We don't have our own data. We don't have our own centiles. And, we are using what the world uses. And then a lot of these guidelines also actually come up from institutions, where they are those university hospital where these things are used. But, majority of us in India practice, we are into private practice, and that actually makes us, there is always a little bit of difference in your thinking and your decision making between what you do in private practice and what you do in a university hospital. So with this, I start with one prelude that decision making in FGR is a major challenge in antenatal care. And the reason is that the concepts keep changing and there are a lot of gray areas. See, what I spoke 4 years back, I stopped speaking 2 years back. What I spoke 2 years back, sometimes when I look back at some of my old talks, I said, how could I say that at that moment? But that was the evidence that was available there at that moment. So there's so much of work which is being done on FGR, and there's so much of evidence that is coming, and based on that we have to keep changing our, so it is very, very important that we keep ourselves upgraded. I was going to take you through more of cases primarily, but then I was sent a lot of questions on my WhatsApp, some forwarded by Sanjay Desle, some by Manjusha, and some of them came directly to me. And I realized that yes, before we get into the cases, it's important that there is some clearing of concepts is important, and then a lot of these questions that has been asked will be answered as a part of when I am explaining that particular thing also. Now, fetal growth restriction is defined as the failure of the fetus to meet its growth potential due to a pathological factor, and that is most likely what you call the placental dysfunction. Now, how do you assign, how do you get the growth potential? That is a concept which is very difficult to gauge. So what are we doing? What we are doing is we are using the fetal size as a proxy. We know it has its limitations, but that's the best thing that we have at the moment. And so we are using fetal size as a proxy. So what becomes the definition is that a fetus with an estimated fetal weight less than 10 centile on ultrasound, that because of a pathologic process has not attained its biologically determined growth potential. So the word pathologic process is also very, very important. Before I dwell further, because there were some questions asked on the technique of particular Doppler waveforms and how to acquire them, I will take you through some technical aspects of that also. That will answer, I think, nearly 30% of the questions that have been asked for. See, Doppler, why Doppler I say is a very, very good modality, because it actually it's an early indicator of fetal compromise. It deals with active work. When I talk about biophysical profile, I'll have to sit with the probe, wait for 30 minutes, and make the fetus do do the movements or breathe. But when I'm doing a Doppler, it is active. I go to a vessel, I take a waveform, and I come up with my interpretation about that. So, some considerations, of course, these are all the general considerations, but there are a few things that you need to be very, very careful about. And one is the wall filter. I will speak about that. And then fetal behavioral state. These are two things which are very, very important. And of course, prudent use in the sense that you just don't have to keep on doing. If once you have got a few good waveforms, because especially when you're doing an MCA, you need to limit your Dopplers, because the MCA flanks the greater wing of sphenoid, and we know that it's a very fragile bone. And we also know, of course, now the new machines come up with pretty good energy restraints, but then still a PW Doppler creates the maximum energy. So we need to be careful about that. Why wall filter is because if you use a high wall filter, lot of these diastolic flows would not be seen, and you would falsely label it as either a high resistance or an absent diastolic flow. This is the same fetus with a high wall filter and with a low wall filter, and this is where this I would have probably called it as a very, very high umbilical artery PI. But now I know once my wall filters are correct, this is perfect normal. Behavioral state, yes, we don't want the fetus to be breathing. There should be no body movements. There should be no hiccups. Once the fetus is breathing, you get these kind of erratic waveforms. And if you take the PI values with this, you're definitely going to be wrong. So you need always got to wait once the movement has subsided, wait for some time, and then once the breathing is subsided, that is the time you're going to do your Doppler there. Fetal heart rate. Now, this is something which nobody talks about, because see, for us, a range of normality of fetal heart rate is anything from 120 to 180. But if you notice, you can start noticing it from tomorrow onwards when you're doing it. See, if even like if you have a little heart rate which is on the higher side, and then you will find that the PI will, it's inversely proportional to the heart rate. So suppose you are dealing with, like, here I am dealing with a heart rate which is 125 beats per minute, and there you can see that the PI is 0.71, and when the heart rate is 96 beats per minute, become 1.72. So you have to be very careful. So the best is if you can get a fetal heart rate between 140 to 160 is something. So if you have taken a waveform and if you find that the PI looks to be very high, then look at the heart rate. If you feel that yes, the heart rate is, there is a bit of a bradycardia there, then definitely you wait for some time, take another waveform or there. If you find that it is appearing low, and if you find that there is the fetal heart rate is 164, 165, fine, that's normal. It's within the normal range. But then you wait for some time and you will find that the PI would change. And if you can get it between 140 to 160, it is good. This is another paper from our own Dr. Anirudh Badade, where he brought out that the effect of fetal movements and fetal breathing on MCA pulsatility index. It really makes a lot of difference. And, a lot of times that we talk about where a lot of questions on the MCA PI being low or less than fifth centile, or the CPR being low, majority of the cases are because of a technical consideration. And that is why once there has been a fetal movement, you need to wait for a few seconds, and then once the fetus has stabilized, you're going to take your waveforms. Now, vessels to be examined: uterine artery, umbilical artery, MCA, ductus venosus, aortic isthmus. I'm saying query, 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 because aortic isthmus now has gone out of the reckoning. Yes, this has had the maximum waxing and waning. Aortic isthmus came with a bang. Everybody started talking about aortic isthmus. Then some literature came which said no. Then again, a few years back, again it came into vogue. But now we realize that yes, it is not really adding much. Yes, it talks about morbidity, but it doesn't help us much in understanding the gravity of FGR, or it doesn't help much in the staging part of it. Now, umbilical artery and all, I'm not talking about, because everybody knows how to do it. Yes, umbilical artery should be done in a mid loop. That's very important. We don't do it at the fetal end. The PIs will be higher. At the placental end, the PIs will be lower. MCA, the only precaution that you need to take is do not use undue pressure. If you use undue pressure, you are going to falsely reduce the diastolic flow, and your PI, which was otherwise would have been abnormal, would become normal. Ductus venosus, somebody had asked for. How, generally, like in the first trimester, we are used to taking it in the mid-sagittal longitudinal plane. You can still do it in the second and the third trimester, but it is much more difficult. So you can go by an oblique transverse plane, take an oblique transverse plane, trace the umbilical vein, and you will find this area of aliasing. That is the place where you need to put your sample box, and the sample box should be of the size which fits into it, so that you get good, you don't use a very, very large sample box there. Aortic isthmus, as I said, we are not, but since there were a few questions on where to take the aortic isthmus waveform, just because I don't know, tomorrow again the literature may come and say that okay, no, aortic isthmus is also important, so we will keep our fingers crossed till then. But then the aortic isthmus is that part of the aortic arch which after the left subclavian artery is gone and before it meets the descending aorta, that little portion is the aortic isthmus. So you can do it in two ways. Either you take the sag, what we do as the aortic arch view, and that is a place where you are going to put your sample volume, or you can do it in the three vessel tracheal view. So we have the pulmonary artery, the ductus arteriosus and the aortic arch, and just before it enters here, that is the place which is the aortic isthmus, and that is where you need to put your sample volume. And we will not dwell into that. What is abnormal in aortic isthmus? Aortic isthmus normally will give you a forward flow in diastole. But if there is a reversal of flow in diastole, then you will call it as abnormal. So forget the aortic isthmus index and all those things. They are not important. Only thing that becomes important is whether there is a reversal of diastolic flow in the aortic isthmus. So we come back. We have already seen this definition that, okay, a fetus with an estimated fetal weight with less than 10 centile because of a pathologic process has not attained its biologically determined growth potential. Now, every fetus which is less than 10 centile, is it fetal growth restricted? No. So that answer is a big no. Every fetus which is less than 10 centile is not fetal growth restricted, because we said that it should be because of a pathologic process. So in fact, 60 to 70% of the small fetuses are actually normal small fetuses. They are constitutionally small. 10% are small because of fetal causes or maternal causes like infections or fetal chromosomal abnormalities or structural abnormalities in the fetus or syndromic fetuses, and 20% is because of the uteroplacental cause. And that is what we actually are going to dwell into today's talk. We are not getting into the other aspects of that. So we have two things. We have SGA and fetal growth restriction. SGA, very difficult to define. Anything which is less than 10 centile is small for gestational age. Fetal weight or AC less than 10 centile is small for gestational age. But now what in that criteria, we have to see which are the ones which are fetal growth restricted. So once you have excluded primary defect, you have an isolated small fetus. Now you will find that, why this differentiation is important, because this segment of fetal growth restriction, what we call as fetal growth restriction, they are the ones which have poor perinatal outcome. They can have IUFD. Their placental insufficiency is the cause. They will show Doppler signs of adaptation. We don't want to prolong these pregnancies after 37, 38 weeks. Whereas on the other side, we have this group of SGA, which could, in most of the cases is constitutional. You may not have Dopplers, you will not have Doppler signs of adaptation. The outcomes are generally very good. There is no stillbirth in these kind of cases. We can prolong these pregnancies up to term. And so that differentiation is required. And how do we do that? If you have an estimated fetal weight less than 10 centile and you have a uterine artery which is abnormal, or a CPR which is abnormal, or an umbilical artery PI which is abnormal. So you have a uterine artery PI greater than 95th centile, or a CPR less than 5th centile, or an umbilical artery PI greater than 95th centile, we will call it as FGR. Or you have a situation where Dopplers are normal, but the fetal weight is less than 3rd centile. That means there is severe smallness. So once there is severe smallness, then by itself, we are going to label this as fetal growth restriction, because even if the Dopplers are normal, but the weight is less than 3rd centile, then definitely we will put them as fetal growth restriction. Whereas you have a fetal weight which is less than 10 centile, that is between 3rd and the 10th centile. So less than 3rd centile, we have already said is FGR, and you have normal Dopplers, you will call them SGA. So that is small for gestational age. But can you just shove them off? Can you just say that, okay, this is just SGA, and so there is nothing to worry? But these are also the ones which we need to follow up. They are the ones which we need to follow up. Now, there is a consensus definition of fetal growth restriction by Delphi, where they have classified FGR into early onset and late onset. Now, remember one thing, early onset and late onset FGR, this 32 weeks is a very, very arbitrary differentiation. So, because some were saying it should be 34 weeks, some said 33 weeks, some said 31, some said 32. But remember one thing, the Delphi consensus was not like 100% consensus, because majority of them felt that 32 weeks is a better place to differentiate between the two. But what is important is that early onset is when the FGR is diagnosed before 32 weeks, and late onset is when FGR is diagnosed after 32 weeks. Now the issue can be that the process onset must have started earlier, but you are diagnosing it because the patient didn't undergo any scan before 32 weeks and has come to you at 34 weeks. There were a few questions on that. So honestly speaking, the primary differentiation between early onset and late onset is that in early onset, you will find, what you call the placental insufficiency is severe. The placental disease is severe. In late onset, the placental disease is mild. Because it is severe, the growth restriction starts early, all the manifestations start taking place earlier, and that is why it is called as early onset. When the placental disease is mild, the things would happen later on. Things would happen later on. The nutritional deficiency is not much, and that is the reason the smallness is not very, very significant in late onset FGR. This is again from the Barcelona group, where they said that the problem with the early onset is management. Diagnosis in early onset is easy, but in late onset, the diagnosis is the one which is difficult. The management is easy because prematurity is not something that we are worried about in late onset FGR. Fetal size is maybe very small in early onset. So all early onset FGRs are SGA. Now fetuses will not necessarily be very small in late onset. Placental disease is high here, placental disease is low here. Abnormal umbilical artery is high in early onset FGR. In late onset, it is low, or you may have an umbilical artery which is pretty normal, or it may become abnormal very, very later, and you will not find the classical cascade of umbilical artery becoming high resistance, then absent diastolic flow, and that kind of an umbilical artery abnormality you will not see in late onset FGR. The incidence of preeclampsia with early onset is very high, 50%, with late onset is less. Hypoxia is more in early onset, it is less in late onset, but the tolerance to hypoxia in early onset is better, whereas the tolerance to hypoxia in late onset is poor. That is the reason. And in fact, late onset is the one which is seen, is the one which has got a higher incidence as compared to early onset. Because the tolerance to hypoxia in late onset is poor, they can suddenly go into an IUFD. Whereas in early onset FGR, we have seen a finding. There is a cascade of things that's going to happen. We know that, okay, umbilical artery is showing high resistance, it's not just going to go into an IUFD. It's going to go through a process. You will have absent diastolic flow, you'll have reversal of diastolic flow. All these things are going to take place. The ductus venosus will get abnormal, but where late onset, because the tolerance to hypoxia is less, you find that suddenly you find some abnormality, you find that the CPR is less, you find umbilical arteries maybe just showing a little high resistance. And if you just leave it and you don't go into closer surveillance, suddenly you may find that either the NST is abnormal or there is an IUFD. That is why we need to be careful about late onset FGR. Now, the ISWAG definition has actually, what I have said, everything is actually nearly the same. But okay, they have divided the definition into what is the solitary criteria. So if you have an EFW or AC less than third centile, it is FGR. Or you have an umbilical artery which is showing an absent end diastolic flow, you can label it as FGR. Otherwise, what we have said before, AC, EFW less than 10 centile with either an uterine artery abnormality or an umbilical artery abnormality, they haven't used the CPR. The Barcelona says that we can use the CPR. Very honestly speaking, we need to use the CPR because the CPR becomes abnormal even before you may have an umbilical artery which is at the 80th centile, you have an MCA which is at the 12th or 13th centile, both within normal range, but at that time the CPR would be less than the fifth centile. So CPR actually is more sensitive, will tell us before that things are going wrong so that you can put them into a higher surveillance. Late onset definition, ACEFW less than third centile is a solitary criteria, and contributory criteria is that if you have an AC or EFW less than 10 centile, or you have an AC or EFW crossing two quartiles. Crossing two quartiles means it is reducing by 50 centiles. So it is at the 20th centile. Fetal weight is at the 20th centile, but it has come from the 70th centile to the 20th centile. So it has crossed 50 centiles. So that also should be taken as a criteria for calling it as FGR. And then you have an umbilical artery PI, which is greater than 95th centile, or a CPR less than the 5th centile. Barcelona puts it the other way around. They have given even for early onset the CPR, and if you have a fetal weight less than 10 centile and you have a uterine artery also which is abnormal, we need to take it as FGR. Now, decision making in early onset FGR and management. Why it's so important? You know, the thought process is so important because every day the fetus spends in utero, the morbidity reduces by 2%. So before 28 weeks, every day the fetus spends in utero, the morbidity will reduce by 2%. And after 28 weeks to 32 weeks, every day the fetus spends in utero, the morbidity will reduce by 1%. So what we want is, we want the fetus to spend as much time in utero as possible, but at the same time, we don't want the fetus to become hypoxic or so to become acidotic. So you are basically, you need to have a mental fight between prematurity and hypoxia. So what decision making in early onset FGR, what all do we have? We have umbilical artery, ductus venosus, two very, very important vessels, umbilical artery and ductus venosus for decision making. I'm not talking about for diagnosis. Then computerized CTG, which we don't have in India, so let's not get well into it. NST or the CTG, the conventional NST, fine, that's the only thing which is available, we will use it. Biophysical profile, most of us have stopped doing it, but again, in late onset, its value has again started coming up because we want the fetus to spend more time in utero in certain cases. So we always want, you can use a modified biophysical profile whenever required. Anyway, we are taking Liker, NST anyway is being done, then fetal breathing movements and others can be looked for. Now, the ISWAG guidelines which have come up, they have, practically they're telling the same thing, but in their criteria, they have said that if the fetus is between 26 to 29 weeks and you have an absent or reverse DVA wave, you will deliver. Anything more than 26 weeks, and if you have spontaneous persistent FHR decelerations or altered biophysical profile for less than 4, that needs to be delivered. But between 26 to 29 weeks, they've said a reverse DVA wave. I'm not talking about the STV because that is coming from computerized CTG. Between 30 to 32 weeks, if you have an absent reverse DVA wave, again, you need to deliver. 32 to 34 weeks. But at the same time, they have said even permitted after 30 weeks, umbilical artery, reverse end diastolic flow, you can do it, or greater than 34 weeks, absent end diastolic flow, you need to deliver, but permitted even after 32 weeks. Now, if you look at all this looks too complicated. Now, what Barcelona has done is they have come up, the Greta Cost team has come up with the Barcelona stage-based protocols, I feel, which works very well with India. Even if you don't have too much concepts, you can still take use of that, and and even from a smaller place or a village or anywhere, because there is an app available, you can come up with some judgment. So it's a simple algorithmic approach, easy to follow protocols, can be followed by everyone. There is an app practically telling you the same thing in a simple way, and I think it's better whatever comes in a simple way. So what they've done is they've divided it into 4 stages. Stage 1 is a stage of severe smallness or mild placental disease. So estimated fetal weight less than third centile, or less than 10 centile with a uterine artery PI abnormal, umbilical artery PI abnormal, or a CPR less than fifth centile. So if you have this stage 1, 37 weeks deliver, that is what the Barcelona protocol says. Whereas you have the Delphi consensus and all, they say something else, but it's all nearly the same. But let's first understand this. I'll show you what are the little differences between them. And if it is not 37 weeks and you have stage 1, then you follow this up weekly. Stage 2 is severe placental disease, where you can have an absent end diastolic flow in umbilical artery. Aortic reversal, it was initially there, even they have removed it from there. Now, if you have an absent end diastolic flow in umbilical artery, 34 weeks you deliver. If not, if 34 weeks, you do it twice weekly. You follow up twice weekly. Now, that is where the ISWAC guidelines have said the same thing. Absent end diastolic flow, 34 weeks deliver, but can be used even at 32 weeks is the criteria they have said. That yes, even if you after 32 weeks also, depending on a case, you may also deliver with an absent end diastolic flow. Barcelona says no, we repeat it bi-weekly. Stage 3 is the stage of early acidosis, where you have a reversal of end diastolic flow in umbilical artery, or then you have a DVPI which is greater than 95th centile. If you have any of these findings and the fetus is 30 weeks, deliver. If it is not 30 weeks, then follow up every 1 to 2 days, on maybe on a daily or every 2 days. You need to follow this up if it is less than 30 weeks. And stage 4 is the stage of severe acidosis, where you will have a reversal of A wave in the ductus venosus or an abnormal computerized CTG, which we don't have. If this is the kind of situation, then 26 weeks you deliver. Otherwise, follow up every 12 hours. So if it is less than 20, now 26 weeks is an international this thing. I would always say that at the time of decision making, also take into consideration what is the kind of NICU that you have, what are the kind of facilities that you have. If it is 26 weeks with the limitations of the place, it is always better that you have a proper counseling with the parents and the neonatologist or the pediatrician, whoever is available. Sit and tell them what is the risk if we continue and what is the risk if we get this baby out at 26 weeks, which could be too premature. But then if it is not 26 weeks, then follow up every 12 hours is what has been recommended. So this is the complete Barcelona thing. For those who don't have it, they have given us the 4 stages. They have given what is the criteria. They have given how should be the monitoring, and they have also given at what stage should we deliver and what should be the mode of delivery also. Now that is where I think a lot of times we are going wrong. Every time there is a Doppler abnormality, stage 1 and all, people say that I'm a very strong propagator of Doppler for every growth scan. Now, okay, there are quite a few in the world who do, but there is a lot of people who feel, and they're quite right in the form that they say that if you use Doppler for as a routine, you end up with more numbers of cesarean sections and all. But that's more happening because any Doppler change is not an indication for an LSCS. Now, because they are very, very clear, even very, very clearly said that if it is stage 1, 37 weeks labor induction, they're not propagating that you do an LSCS for stage 1. They have asked for a cesarean section for stage 2, 3, and 4, unless of course there are other indications for an LSCS there. Now let's see some cases. 28 years primary for a scan at 30 weeks. Bundle height is little low, gained 7 kg. That was all fine. Now you have an estimate, you have an AC which is at the 9th centile. Estimated fetal weight is less than the 14th centile. So AC less than 9th centile. Now, can I call this as FGR? Or should I ask I need to get some more information. So first thing, I need to look at my dates. Dating scan was corresponding. NT scan was also 12 weeks, 3 days was corresponding. Uterine artery PI was normal then. Second trimester also corresponding. Everything was normal. PI was normal. So I do a Doppler and I find that the CPR is at the 5th centile. Rest all parameters are normal. CPR is at the 5th centile, not less than the 5th centile. So is this FGR or no? This is an SGA at the moment. But can I neglect this? I'm having an AC which is less than 10 centile. CPR is borderline 5th centile. No. So, but because I've not labeled it as FGR, I'll follow it up after 2 weeks. Now, 32 weeks, EC is at the 8th centile. Now the fetal weight is at the 10th centile, but the umbilical artery is 95th centile. CPR is 4th centile, less than the 5th centile. So now is this, important question comes to me, is this FGR? Then what stage it is? And when would I like to follow up? I need to answer these 3 things. Now, is this FGR? Yes, it is early onset FGR. Now, once I have labeled it as FGR, I know this is stage 1 because I have a fetal weight or AC less than the 10th centile and the CPR is less than the 5th centile. So falls into the criteria for stage 1. Now, when would I like to follow this up? I would like to do it after 1 week. But then generally, whenever we suggest 1 week, patients come after 2 weeks. So this patient came after 2 weeks at 34 weeks. The AC is 4th centile, estimated fetal weight is also at the 4th centile. Now the umbilical artery is gone more than the 95th centile. CPR is 3rd centile. Ductus venosus is normal. It is still stage 1. I will follow up after 1 week. 35 weeks, umbilical arteries still showing diastolic flow. Of course, the resistance is increasing and ductus venosus is still normal, still stage 1. Will I think of delivery? No. I will follow protocols. I'll follow up after 1 week. 36 weeks, fetal weight is at the 1st centile, but umbilical artery is still showing diastolic flow, very high resistance. Ductus venosus is normal, still stage 1. Will I deliver this or ask for a delivery? The answer is still no. I'll follow up after 1 week. 37 weeks, and that is the time where, though it is still stage 1, we have brought this fetus, all the way up to 37 weeks, and that is the time we can definitely go ahead with delivery of the baby. So mode of delivery, of course, as a radiologist, I don't comment on that. But yes, the protocol says that yes, you can induce induction of labor is what is recommended. So what from this case we can see that we have prevented iatrogenic prematurity and we have reduced that because we followed an evidence-based algorithmic approach and clinical surveillance. It is not that we have shirked off and we have that go, no problem, nothing will happen, it is stage 1. No, we have been following it up. We just were monitoring it on a weekly basis until the time we felt now the maturity is good enough. There is no problem that 37 weeks the fetus has reached, and that is the time when the delivery took place. Case 2, IVF 3rd cycle, early pregnancy scan, CRL 7 weeks, 4 days. Dates were corrected at that time. Now this patient has come at 19 weeks, 5 days and 19 weeks, 5 days. By corrected dates, of course, and you have an AC which is less than the 1st centile. All the parameters are less. Estimated fetal weight is at the 3rd centile. Now, is this fetal growth restriction? Yes, straight away, it is fetal growth restriction. Do I need any more information? Yes, because this is 19 weeks, 5 days. And at the same time, I'm also finding that all the parameters are small. So it's everything is small in this case. So I would first of all look whether there has, because when you have an early onset FGR, always think of the fetal causes also, cause in the fetus. So I looked into the first trimester screening, which was done outside, which was low risk, but uterine artery evaluation was not done at that time. in the present scan, there were no structural anomalies, no soft markers of aneuploidy, because all these things are important for me, before just labeling it as a placental cause. In all such cases, we need to rule out genetic association. And when I do the Doppler, yes, we have an umbilical artery PI, which is high resistance flow, and you will find that the mean uterine artery PI is also very, very high. And then you have an MCA with CPR, which is low, MCA PI, which is less. So you have all Doppler changes, which are significant there. The ductus venosus was normal. Now, what stage is this? And do we advise any other indications? This is, and the third question which comes into mind is, what do I counsel this patient? 19 weeks, 5 days, severe fetal growth restriction, already showing Doppler abnormalities. We know that at least 26 weeks is required somewhere for the baby to have a good chance to survive. Now, should we advise termination at this stage? All these things come into your mind. And then if the patient wants to continue, when would you like to follow up this case? So this is stage 1. There is no doubt about it. There is no structural anomaly, no soft markers. We did a torch test, which was normal. Patient refused testing for chromosomal anomalies. They said no, because very, very precious pregnancy. They wanted to give this baby the best chance that was possible. All the pros and cons were discussed with the patient. And now this is 19 weeks, 5 days. Because this is stage 1, should I follow protocol and repeat after 1 week? What am I going to gain after 1 week? Nothing. So after 1 week, if I find there is absent diastolic flow in umbilical artery or reversal, I'm not going to take any decision. So I said, you come at 24 weeks. Because you want to continue, come at 24 weeks. Because anyway less than that, we are not going to do any or take any decisions. But the patient came at 26 weeks, 5 days straight away. Of course, things had deteriorated by then. So means as far as the biometry is concerned, you can find that everything is been dipping down. The fetal weight has also come down. Umbilical artery is now showing reversal of the diastolic flow, and you have an aortic isthmus and the ductus venosus, which is normal. So 26 weeks, 5 days, we have reversal of end diastolic flows. Second, and you have an estimated fetal weight, of course, which was 445 grams, less than the third centile, surely. Now, what stage is this? This is stage 3. So we are dealing with a stage 3. So now should we deliver? 26 weeks, 5 days, stage 3, should we deliver? The protocol says no. If it is stage 3, because we have a ductus venosus, which is still normal, but then you need to follow up on either daily or every 1 or 2 days. So we asked for a repeat after 2 days, but then by the time the patient had understood that, the more time the baby spends in utero, things would be better. So they came after 4 days. Again, you have a reversal of end diastolic flow, but now the only thing is there is aortic isthmus reversal, and there is also a DVPI, which is greater than 95th centile. Now this is again stage 3. We are still dealing with a stage 3. Of course, now that is the time when you take a call between whether you want that extra 1 or 2 days, or you just want to get this baby out. The patient was quite keen, and then decided to they still wanted to wait, and definitely protocol wise we could wait. And so 27 weeks, 5 days, and that is the time there is reversal of diastolic flow, and that is it. Okay, now this is gone into stage 4, and this baby was delivered, and a 485-gram female baby was delivered by LSCS. Baby spent 40 days in an ICU, went home. So early onset FGR before 30 weeks, the critical endpoint should be a critical abnormality in the ductus venosus. Every day a fetus spends in utero before 28 weeks reduces the morbidity by 2%. Now, this is a case of who was hypertensive. Everything was corresponding 12 weeks, 3 days. Anomaly scan was corresponding at 20 weeks. She had a history of hypertension from 27 weeks in her first pregnancy, and she had undergone an emergency LSCS at 34 weeks. And her first trimester, uterine artery PI was high. Even in the second trimester, the uterine artery PI was high. So thinking all that, best part was we thought that we will not wait till 30, 32 weeks. We will ask her to, we have an early growth scan at 28 weeks. She came at 29 weeks, 5 days, and you have an increased umbilical artery PI, and you have a DV which is abnormal. BP is 170 by 96, fetal edema, albuminuria. It is stage 1, but okay, stage 1, we will follow up after a week, 30 weeks, 6 days. You have similar findings here. Now the BP is 180 by 100. It is still stage 1. So we asked for a follow-up after 1 week, 31 weeks, 6 days. You have similar Doppler findings. Of course, the biometry, the fetal weight is, going down. This is still stage 1, but now there is fetal edema, there is albuminuria, there is maternal ascites. So now at such a situation, your Barcelona staging and everything goes for a toss. What is more important is the mother, and hence the delivery was decided. So maternal condition supersedes everything. That's a very, very important message that we get. 25 weeks, 1 day, sent for anomaly scan. Dates were corrected. You have fetal weight at the second centile. Everything, all parameters are less. Definitely fetal growth restriction. There is no doubt about it. Doppler is showing you an absent diastolic flow. The DV is normal. So once you have an absent diastolic flow, this becomes stage 2. So this becomes stage 2. And with stage 2, 25 weeks, 1 day, we will not deliver. We will wait. When would you like to follow up? Advise bi-weekly scans. But she came at 26 weeks, 4 days. Again, the same findings. 27 weeks, 3 days. Again, the same findings. But in between, we were doing an NST, every 2 to 3 days between Doppler scans. NST was reactive. 28 weeks, 4 days. Again, absent diastolic flow. Findings are the same. But, this is still stage 2. So again, follow up. 30 weeks, that is the time when there was a reversal of end diastolic flow in the umbilical artery. And once that has achieved, and we have achieved 30 weeks, we have gone into stage 3. Stage 3, 30 weeks, all protocols say that, yes, we need to get this baby out, because definitely in such a case, the reverse end diastolic flow in umbilical artery is more, has more risk than prematurity. And that is why you end up delivering this. And I will skip this. FGR with anomalies had genetic association. So early onset, think of genetic associations with that. Now we move to late onset FGR. What has happened with my can I just unshare and share again, please? Hello?
Yes, sir. Yes, sir. No issues.
Yeah, I will, or maybe, okay, this is the same one. Fine, no problem. No problem, no problem. Okay. Now, between early onset and late onset, with a sip of water, I just want to make an appeal to everyone to register for UltraFest. That's the biggest ultrasound event that takes place in India. And this time it is in the city of Pune with a lot of different things. We have Dr. Nicole Volpe from Italy, who is going to be our esteemed foreign faculty, and then all our national stalwarts, Nemicha Yashasvi Kalakar, they are all going to be there. So, and our organizing body, our president and secretary have actually been kind enough to, continue the discount till 31st of December. So Merry Christmas to all. And I think let's take an advantage in 2022 itself by registering for UltraFest. Now we move to late onset FGR. Now it is defined as an inability of a fetus to reach its growth potential, diagnosed after 32 weeks of gestation. Now, is it different? Yes, it is commoner. Fetal size is usually not very small. Umbilical artery is usually normal. An AGA at 33 weeks may become an SGA at 37 weeks. So to date, there has been no A-grade evidence supporting the monitoring strategy and timing of delivery in late onset FGR. Screening tests in early pregnancy have limited predictive value as far as late onset FGR is concerned. That these are some of the things that is totally different. Now, when we talk about placental function, there are two things, nutrition and oxygen. Now, smallness happens because of reduced nutrition, because of malnutrition, whereas fetal compromise happens because of respiratory hypoxemia. Now, if you look at this curve, you will find that the curve for nutritional needs, which is the curve which is in green, this has a logarithmic, curve, whereas the one with the respiratory need, you will find that there is an exponential increase towards the, as we go into the third trimester and later. So the respiratory requirement is much more that happens later on in pregnancy, and the nutritional requirements are not as significant as it is in the early part. So late onset FGR, AC estimated fetal weight less than third centile definitely is FGR, or it is less than 10 centile. And here we also have added that if it is crossing two quartiles and you have an umbilical artery PI which is less than 95th centile, or a CPR which is less than the 5th centile, or a uterine artery which is abnormal, this is from the Barcelona, then we call it as FGR. And if it is less than the 10th centile, or between the third and the 10th centile with normal Doppler, we will call it as SGA, but we will follow this up. Okay, this is where this has come. I thought I had probably did not save this. So this is the UltraFest invitation for you all, the 28th, 29th, 30th of April, and we have and all these stalwarts that you know all going to be there. I'm also going to be there. We have Dr. Adinarayan, Dr. Kurana, Dr. Chawal, Dr. Asif, Alpana, Anirudh, Dr. TLN Praveen, and of course our one person who has been a star of UltraFest over the years, Dr. B.S. Ramamurthy. All of them are going to be there. And yes, you have a special discount till, so you can use the code XMUS22 and you will get a discount on your registration. Now, in late onset FGR, definition we have seen. Now, how do we do the management? As I said, there is no international consensus when to deliver in late FGR because there is a lack of interventional management, randomized trials based on Doppler indices in late FGR. So there are issues, but still there have been guidelines. There are things which have come up. So whatever is there and how best we can do it, we look into that. Now, what tools that we use in the for decision making in late onset, we use CPR. We use biophysical profile. CPR we use more for diagnosis rather than a decision making, but then the Doppler the MCA, the CPR becomes more important here because the brain becomes important. The brainstem becomes important. The brainstem becomes more responsive to hypoxia later on in pregnancy. The brainstem becomes more responsive to hypoxia, and that is why you have the changes that take place. You have the changes of, when we say that the biophysical profile becomes abnormal, or there is a breathing abnormality, or the tone is gone. Now, these are all things which are happening because of the brainstem, and that happens in late onset FGR mainly. And then biophysical profile, daily movement count is an important thing which the mothers should know. And we have our conventional CTG or NST. Now, CPR, I think 60% of the questions that have come to me so far were on CPR. Now, it has a very, very high inter and intra observer variation. This is what I want to begin with. You do a MCA and an umbilical artery over a period of 10 times over a period of half an hour, you are going to find things which are different, because so that is why this kind of variability takes place. And hence you need to be very, very careful when you call us, you say that the CPR is less than 5th centile or the MCAPI is less than 5th centile. Anytime you find that there is a Doppler abnormality, you better be sure about it before you put it. So best thing is you need to observe, you wait for some time, take another reading, or wait for some more time, take one more reading, or always repeat after 24 hours to confirm the findings. You can have an absolutely very, very low diastolic flow in MCAPI in the today. When you have scanned, you call the patient next day morning and you have an absolutely normal looking MCA. Now that is why you also need to take an overall picture into consideration. I'm not saying, of course, you have severe SGA, all these factors, there is a lot of supportive evidence, then definitely you will give it importance. But otherwise, as a routine, if you find that the CPR, which is falling less than the fifth centile, please get your readings done 2-3 times at that time, or call them after 20. Even the Barcelona thing, actually, if you read the fine print, they say that this is stage 1. The findings repeated after 20, persistent even after 24 hours. Now, CPR less than fifth centile is more for diagnosis and not for delivery decision unless after 37-38 weeks. And CPR less than fifth centile in an AGA fetus, I think this will answer a lot of these questions which have been asked. It prompts us for closer surveillance. It is not an indication for immediate delivery. I have an AGA fetus, 30th centile or 40th centile, and I have a CPR which is less than fifth centile. I'm not actually labeling it as FGR as such, but I have a CPR which is less than fifth centile and which was seen persistently. Okay, now what I'm doing is, it tells me that, okay, even though this is AGA, this could still be growth restriction, and that is why I need to put this fetus into closer surveillance, and that we will see how we do that. Biophysical profile, AFI, NST, NST becomes first becomes abnormal, then the breathing movements go away, then you have the gross body movement gone, and then the tone goes. That is the sequelae which takes place. But then, because we are into ultrasound, the breathing movement, we don't want to go into the gross body movement or the tone which is lost. So breathing movement is something which we should get used to. So in fact, if you are getting good, very, very erratic waveforms on Doppler, which you feel is not like a hiccup, then actually that is very reassuring. That means the fetus is breathing. Now, monitoring. The primary goal of monitoring, like I'm talking about monitoring in late onset FGR, is prevention of stillbirth. And this can, we want to know fetal deterioration. Now, CPR less than fifth centile, weekly or bi-weekly, you can, in late onset FGR, you need to monitor, because this study has shown that 90% of the stillbirth in a large study occurred within 1 week of a normal biophysical profile in the presence of cerebral vasodilatation, suggesting that biophysical profile may be poor in determining the frequency of fetal monitoring, and hence CPR less than fifth centile is something that you can use for monitoring late onset FGR. Now, when to deliver? Again, the ISWAC says 36 to 37 weeks, 6 days. You have an umbilical artery PI which is greater than 95th centile, or an AC AFW less than third centile, you deliver. Or after 38 weeks, if there are any signs of cerebral redistribution, that means CPR and everything, they talk about it. But the Barcelona staging, says that 37 to 38 weeks, even if it is, you have a fetal weight less than 10 centile and you have a CPR which is less than the fifth centile, you need to get this baby out. Now, late onset FGR, we talk about. So we saw in the beginning that all SGA fetuses are not FGR, but are all FGR fetuses SGA? That is also a no. So it is not necessary for in every time for a fetus to be SGA to be fetal growth restricted, because again, the 10th centile that we use again is an arbitrary thing. It can, if you use just the 10th centile, it can cause underdiagnosis of growth restricted fetuses who apparently are grown normally, but they have the risk of adverse outcomes. And sometimes constitutionally small fetus may unnecessarily be labeled as FGR. But then, as I said, with all that limitation, we are using it. Now, if you look at this study which came from Netherlands, highest mortality is when, of course, definitely less than the 2.3 centile or less than the third centile. But it is not that there is no mortality or stillbirth taking place at the at the 20th centile or at the between the 20th to 50th centile. So there is so some of them could be. Now this study again has shown that if you look at this, you will find, yes, the maximum amount of FGR is in the SGA category, but it is not that in the AGA category you don't have fetal growth restriction. Now the problem is, how and when do we how do we actually do this? Because again, this is again coming from the Nicolaides group, that majority of preterm stillbirths are SGA, but majority of term stillbirths are AGA. And that is the reason I feel that you have an AGA, you need to give it importance. I'm not saying that you have an AGA, with some Doppler finding, you're just getting this baby out. No. But if you have an AGA, and that is why I feel that, yes, how are we going to, if it is an AGA, if with all this literature which is coming up, how are we going to find out whether, yes, this has a potential of having an abnormal outcome? The only way out is Doppler, and hence we need to do Doppler for every growth restriction. Problem in India. So it's very easy to say that crossing, fetal weight less than 10 centile, this is a universal problem. Which growth chart should you use? That is a question. I think I've got four, 5 people who have written that. Which growth chart should you use? Now, I'm the same weight 1917. If you put on the Mediscan chart, which is an Indian chart, it is AGA. You put on headlock, it is SGA. You put on intergrowth, again it is AGA. WHO, it is SGA. So we land up into so I can always, any estimated fetal weight, I can use one chart and put it as AGA wherever I want it. Or if I want to make it SGA, I will do it if I put it on other charts. Dip in growth velocity, Indian problems. These are scans which are done at different places. NT done somewhere, dating done somewhere, second trimester scan somewhere. Then the growth scan has been done twice somewhere, and the third time they've come. It is very difficult for you to assess the dip, because everybody has used different charts. They may not have actually given you the biometric measurement all. So that is again a problem. So we will just see what we can do with the late onset FGR, which is AGA, also is important. Now, if it is an AGA that is above the 10th centile, but it is crossing 2 quartiles, no problem, because that is coming as a definition. It is falling from the 75th centile or to the 25th centile, or the 60th centile to the 10th centile, and there are Doppler abnormalities. This is also to be diagnosed and managed as late onset fetal growth restriction. So far, so good. The question comes is, you have an AGA, velocity is not known. Now, if the estimated fetal weight is between the 10th and the 50th centile and has an abnormal CPR, this has an association with abnormal perinatal outcome. This is again come from literature. This is not something which I am saying. So an AGA at 32 weeks may become an SGA at 36 weeks. So suppose I do a scan at 32 weeks, it's AGA, I just don't bother about it. But if I have done Doppler and if I find that there is a CPR which is less than 5th centile, I will definitely ask for a closer surveillance. And because out here patients may just disappear, they may come directly for delivery. So you need higher surveillance when you have a considered like this. So after 36 weeks, if the fetal weight is between 10th to 50th centile, so I'm saying 10th to 50th centile, and if there are changes of hemodynamic redistribution like a CPR which is less than 5th centile or an MCA which is less than 5th centile, you need to put them into strict surveillance and follow-up. But if there is an abnormal CTG, or there is an abnormal biophysical profile, or the patient is saying reduced fetal movements, or you are finding that the CPR has really dipped rapidly, then you can definitely consider delivery in these cases. Otherwise, consider delivery induction of labor at 38 to 39 weeks, even if you have a AGA with just a CPR which is less than 5th centile. Now, we've talked about SGA. So SGA, we feel very, very relaxed. Dopplers are normal. This is SGA only. But, these stresses should be delivered at term. But some SGA might suffer some degree of stunted growth, not adequately identified by current biophysical tools. And hence, ISWAG has suggested that if you have an SGA, you need to do a 2-weekly monitoring of growth and Doppler. It is reasonable to consider the induction of labor after 38 weeks of gestation to reduce the risk of severe growth restriction or stillbirth, and not to exceed 39 plus 6 weeks of gestation where SGA has been identified. 3 quick cases: 33 weeks, 4 days, everything is fine. Fetal weight 14 centile, CPR 7 centile, AGA, no problems with Doppler. But because things are just at a borderline, I just wanted to show you how things happen. I said we will repeat after 2 weeks, but they came okay at 36 weeks, 3 days. And that is the time you can see that now the fetal weight has gone less than the 3rd centile. You have an umbilical artery, which is also with the CPR has gone less than percentile. Their fetal breathing movements were present. NST was advised, and again follow up after 1 week. At 37 weeks, the patient complained of reduced fetal movements. NST was non-reactive, and so the patient never came back for the Doppler. The decision to deliver was taken. Now, this is what happens. So once you do a Doppler, you actually, I'm finding the CPR at the 7th centile. Maybe with a little bit of playing, I could have got it less than 5th centile also. But am I saying no? Yes, you just get this baby out. No, I have a CPR, which is an age. What we did is we asked for closer surveillance. Otherwise, as I said, at 37 weeks, the NST had also become non-reactive. 34 weeks, you have a AC less than is at the 4th centile, fetal weight at the 4th centile, CPR 3rd centile, late onset FGR, follow up after 1 week. Again, the fetal breathing movements were positive, 3rd centile, CPR is at the 1st centile. Now the umbilical artery is at the 94th centile. That's okay, still within normal range. We follow up after 1 week, 36 weeks. Again, you have an EFW 1st centile. Now the umbilical artery PI is 95th centile. CPR is actually dipping, but the NST is reactive. Everything is going well. So we will still follow up after a week. And this is the time when we found that now the umbilical artery resistance has gone above the 95th centile. So it is not that in late onset FGR, you are not going to get an umbilical artery which is going to become abnormal. But it may become abnormal very, very, very late. So the CPR will become abnormal much earlier. It will tell you, because the placental disease is not severe, and that is why the umbilical artery actually in most of the cases remains normal for a very long period of time. So 37 weeks, you will deliver. 19 weeks, 1 day scan done at other place. Everything was fine. Everything was okay here. And then 34 weeks, 6 days, she has come. Now that is the time the fetal weight is at the 20th centile. So AGA, no problem. Should I do a Doppler or not? I do, because that I believe that I should do a Doppler. I do a Doppler and I find that the CPR is at the 6th centile. Umbilical artery PI, but the mean uterine artery PI was greater than the 95th centile. Though it's an AGA fetus, the CPR at the 6th centile, I said we will follow up after 2 weeks. No problem. We'll follow up after 2 weeks. And then she came at 36 weeks, 6 days. The fetal weight has now gone to less than the 5th centile. So this has become SGA. And umbilical artery PI has also gone greater than the 99th centile. The CPR is less than the 1st centile. So we suggested we will either go for a very close surveillance with NST or this thing, or an option of delivery was also offered. Patient opted for a second opinion. The second opinion said that Doppler, the umbilical artery Doppler is not very bad. It will take its own course of time to become bad. So let's repeat after 10 days. And the patient came after 2 weeks because she was very relaxed about it and came with an intrauterine fetal demise. So, that this is what happens. And that is the reason I believe that, yes, we need to do Dopplers. But at the same time, just one reading you've taken and CPR is less and panic. No, we'll be very, very sure about our finding. We will put it into surveillance. We will take use of other this thing. Only thing is we want to prevent stillbirth. Even in an AGA fetus, we want to prevent stillbirth, and that is why we will try to we will use this as an abnormal Doppler finding as a clue to go ahead and look at the fetus more regularly and look for other things like biophysical profile and an NST and all. Now, these are some of the questions which I got. In cases where FL is less, should we include it in calculating gestational age? See, first of all, it depends at what stage you are. And first of all, we don't calculate the gestational age every time. The gestational age will be the age that you get from the CRL, which has been done. Yes, if no scans have been done before and you are in the second trimester or the first time, then head circumference you can use isolated rather than going for a multiple parameter gestational age assessment. In twins, where do we calculate growth centiles from? Very honestly speaking, we are using the singleton growth charts for twins also. Now, there has been that Stokes study and Asma Khalil's paper, which they have said that yes, we overcall SGA because we use the singleton this thing. But at the same time, towards the end, they also pointed out because we are using Dopplers for decision making rather than just the biometric SGA, then we can till the time there is more validation, we can still continue using the singleton charts. Do CPR or any centiles come to normal after once abnormal? Yes, they come to normal more because of technical reasons, or at times you have a cord which is just getting compressed between the head and the uterine wall, and then you find that the umbilical artery PI is showing high resistance, and then once you change or you will find that things can come back to normal. They can come back to normal overnight also, but once a pathological thing has happened, it is difficult. Yes, uterine artery can be abnormal in the first trimester, can become normal in the second trimester. That can happen because there are two stages of placentation. So second stage of placentation may be good, and then the uterine artery may become normal. If isolated uterine artery PI greater than 95th centile, weight is normal, do we label it as FGR, and how frequently do we follow? Yes, weight is normal and the uterine artery is only the uterine artery is abnormal. We don't label it as FGR. We don't label it as FGR because uterine artery is, we are using either for making a diagnosis between differentiating between an SGA and an FGR, or it is a predictor of a possibility of, if you use it in the early part of your pregnancy, it is predictor of fetal growth restriction and pre-eclampsia. But we will just weight is normal and uterine artery PI is greater than 95th centile, we will not call it as FGR. If we scan at 32 weeks, 3 days, this is a wonderful question. CPR and MCA are abnormal. Umbilical artery is normal. Uterine artery PI is greater than 95th centile. Estimated fetal weight is less than 10th centile. Previous Dopplers are not available. So practically, yes, this is fetal growth restriction. There is no doubt about it. But his question is, should we call it as early onset or late onset FGR? You just call it as fetal growth restriction. Because now it depends on what it will behave as. This could, because the umbilical artery is normal, this could be more likely to be, that's what I said, don't go by these arbitrary cutoffs or this. It is about, because the umbilical artery is normal, that means the placental disease is not really that severe, and hence this is happening. But there, umbilical artery at this moment is normal, it may become abnormal. So in this kind of a scenario, but it will, sometimes you find at 33 weeks and you find that there is an umbilical artery which is abnormal. We have to call it as late onset FGR, but it behaves like an early onset FGR. It may, because it must have started earlier, it may also show a ductus venosus which becomes abnormal. So most important is to identify FGR. Hence, assigning gestational age and using growth charts is essential. Early and late onset FGR represent distinct phenotypes of the same disease. Smallness in size is a predominant characteristic of early onset FGR, may not be a factor in late onset term FGR. 40% of late pregnancy IUFD is because of late onset FGR. We have to start getting used to that. An objective protocol based approach to decision making is now validated. ductus venosus evaluation is the cornerstone for assessing when to deliver in early onset FGR. The CPR is a critical index in late onset FGR, and a multi-vessel Doppler should be a part of growth scans in the third trimester. And I can't stop my talk without this poem, which I've been reading every time, not written by me, but by an unknown resident in Dublin, that I am a fetus in the womb. I fear it may become my tomb. If only I could give a shout to make my doctor get me out at the right time, neither too premature nor too hypoxic. Thank you very much. Manjusha, do we have questions?
Pankaj? Hello, Pankaj, can we see the questions? Sir, there is a question from my side. Though ductus venosus is not considered as a decision-making vessel in late onset FGR, why the Barcelona asks is in late onset FGR also?
Barcelona is not differentiated. Barcelona chart is common for both early and late. Na?
Okay.
They have not. They have given the common staging for both. Only thing is, in practice, I feel that the staging works wonderfully well in the early onset. Late onset, there are certain other things which also become important. But Barcelona has the Barcelona does not have it is using the criteria. They have given the staging as a common thing, But they tell you then this is late onset, this is early onset, but they use the criteria. As I said, at times it may have started early. Ductus venosus may become, if it has started as an early onset FGR, but this is again, it's an arbitrary thing that DV will not become abnormal. It is not that. Basically the fetus, because it cannot tolerate hypoxia for a very long period of time in late onset FGR, you have that period is so short. There is not enough time for the heart to work that much, and so that stage of the DV may skip over a period of 1 week, and suddenly you may find that there is a CTG which becomes abnormal. But generally it does not happen because, like my friend Vijay always says, that late onset is happy heart. The heart is happy in late onset. It is the brain which is important.
So yes. In late term babies, we get MCA dilated intermittently. Sometimes you get a very good MCA, sometimes you get a dilated increased diastolic in MCA. Which value we should take?
Always in Doppler, the one which is closer to normal should be used.
Yeah.
Even if you're doing umbilical artery, if you're doing on both the vessels, both the arteries, the one which is closer to normal we will use.
Okay. So I have a habit of taking MCA at least 3 to 4 times.
Yes, very good habit.
Sir, in case where only the uterines are abnormal, how frequently we should monitor? Like when should we call the patient for follow-up?
No, nothing. You got the uterine. Uterine is going to become abnormal right in the beginning only, no?
No, sir. If sometimes uterines become abnormal in the secondary stage of placentation.
Yeah. It can happen in the second trimester also. Sometimes you may get it directly in the third trimester also. That can happen. But if it is not fitting into anything, so if you have it's an AGA and everything, and uterine artery is just abnormal, it depends at what stage. See, if you are at 30 weeks, you can call them at 34 weeks. But if you are at 34, 35 weeks, then you call them after 2 weeks at 37 weeks.
Yes.
Just for you can always take a call based on overall findings rather than just on a uterine artery there.
Yes, sir. Yes. Pankaj, can you share the screen, sir? Pankaj is going to share the screen, and I'll read out the questions if there are any.
Only thing, if there are people still surviving after that 1.5 hours of.
So people are always ready. I mean, I must say that I've listened to your lecture of this so many times, but every single time we get so many new points, and it's really helpful.
Ma'am, can you see my screen?
No, we cannot see your screen. Sir, I think so. You have to stop sharing, then only you can share the screen.
I've already stopped sharing. That's why I'm seen here. I have already stopped sharing.
Just a moment, I'll check.
Okay. Sir, I'll read out the questions.
Yeah.
Can we use CPR criteria in early onset FGR?
Yes, for diagnosis. Yes. No problem, because it is helping you in uh, labeling that SGA as FGR
Okay. Okay.
earlier than before the umbilical artery is going to become abnormal.
Yeah. Now there is a question. In the second case with a reversed umbilical artery before 30 weeks, why was the baby not delivered?
Because reversal of this thing is stage 3, and stage 3 we don't deliver at 30 weeks.
Yeah, it's not the trigger actually.
No, we delivered at 30 weeks. Reversal we delivered at 30 weeks, but before that there was absent diastolic flow. In that case that you're talking about, there was absent diastolic flow. Till there was absent diastolic flow, and at 30 weeks it became reversal of diastolic flow.
Yeah, now the second next question is, everybody faces this problem. With which growth charts do we use? Can we use FMF to see the estimated fetal weight percentiles in Indian sittings?
I really don't have an answer to that. See, the thing is, you need to use a standard chart. Now it is see, there are population standard charts and there are population referral charts. The Mediscan chart is a population referral chart where they have taken the biometry of all the patients who have come, and then they have made those charts. And in that, actually, you have all those cases which were FGR, which were with anomalies, everything has been included. Now, and then it is coming from a tertiary center, so there is always going to be a referral bias in that. So once you put in, but a population standard chart is where you have excluded all these with abnormalities, and only those who are like, well fed and normal babies, singletons, they are the only ones who are you have included. So intergrowth is one of those charts. The intergrowth chart is based on is a standard chart where actually they have done the studies in so many places in the country where they have used well-fed, educated women, the fetuses of well-fed, educated, healthy women without any fetal complications. And so their feeling is that the charts all over the world are the same. There is a lot of controversy. See, this topic is never going to end, whether we should use local population charts or we should use global charts. But our local population charts are actually referral charts. They are not standard charts. So we till the time we have our own standard chart, we will use intergrowth. Hadlock is very, very close to intergrowth, but Hadlock also has its own problems. Maybe for the fetal weight, it is different, but the head circumference usually goes less than 5th centile with a very, very, maybe a 1 week lag also. So that is where all charts have their issues. But at
simple
the moment,
question, what charts do you use at your center?
I use intergrowth and the Mediscan chart, both.
Okay.
With absent end diastolic flow at 32 weeks, fetus is delivered. Yes, you can. Though criteria says 34 weeks, Barcelona says 34 weeks, but the ISWAG guidelines and the FIGO have said that you can do it at 32 weeks also. Now, again, that's why I said, now there's a lot depends on overall situation. It is not just about one particular thing. How bad is the growth restriction? How are the other things? All those things will become important. But then 32 weeks also, precious pregnancy, a call can be taken. Anyway, in India, we err, that 4 days and 1 week, we always err towards prematurity because in practice, we are very, very scared, especially if somebody has had an IUD in the last 1 year. They're so scared that, even whatever you tell them, no, we'll follow up 3 days, 4 days, but the decision to deliver is taken a little earlier than what the protocol would have suggested.
Okay. I think so. That's all. On behalf of MCR and all the attendees, I would like to give you a big vote of thanks, sir. Thank you very much. Sanjay?
Yes, thank you, sir. Thank you very much.
Sir, anything for you?
Thank you,
Thank
Dr.
you, sir.
Bimal. Thank you, Dr. Manju. Thank you, Dr. Sanjay.
Yes, sir. Thank you, sir. Thanks a lot. Yeah.
Good night.
I would like to thank Fuji also for arranging this event.
Thank you so much, man.
Thank you, sir.
Good night.
Right.
Good night, sir.
Good night. Good night.
Good night, everybody.